Hello, everyone. I am thrilled to introduce the very first edition of the EndoTalks podcast. My name is Adrien Crestani, and I'm a gynecologist specialized in minimally invasive surgery for endometriosis. I currently work at the IFEMENDO, the Franco-European Institute for Multidisciplinary Care in Bordeaux, France. And alongside with my esteemed colleague, Georgios Grigoriadis from Greece, Dimitrios Kaletsopoulos from Switzerland, and Johan Dabi from Paris, we are so excited to bring you this new platform. Our goal with EndoTalks is to engage in insightful discussions with authors of some of the most cutting-edge and impactful papers on endometriosis. This podcast is for physicians, fellows, general practitioners, and patients who want to deepen their understanding of endometriosis. We are committed to delivering reliable, up-to-date, and accessible scientific information to help you stay informed and engaged with this very important topic. Thank you so much for joining us, maybe at another time in this podcast. We hope you find value in our conversation. Today, for this first episode, I have the great pleasure to chat with Dr. Konstantinos Nirgianakis. As you've heard, he's from Greece and he's actually the co-director for the Center of Gynecologic Surgery in Heraklion, Crete. He was a resident in Germany, Switzerland, and then consultant for 7 years in Burns University Hospital, where he obtained his PhD. He is the author and co-author of many publications focusing on the pathophysiology of pain in endometriosis, recurrence and treatment non-response in endometriosis and adenomyosis, as well as the impact on fertility and pregnancy of this disease. Thank you so much, Konstantinos, for being with us today. I hope you're fine. I will start very clearly. Dear Konstantinos, 2 years ago, you published in Reproductive Science a systematic review that focused on dietary intervention in the treatment of endometriosis. For our scientific community and for this podcast and for the patient, the question is topical. So I would like you to explain us how you came with the idea of this specific study. Thank you.
First of all, Adrian, thank you very much for the invitation. It's a big honor for me to be invited in EndoTalks. I'm sure it will have an impact for many clinicians, but also for patients. Yes, to start, I see and treat patients with endometriosis for about 15 years. And as we know, endometriosis is a chronic disease, and patients often require something more or additional to the classical therapies, which are hormonal therapies mainly or surgery, so the classical therapies. Indeed, during my clinical practice, I noticed that over the years, more and more patients were very interested in self-management of the disease, which of course included a change on their diet to improve endometriosis symptoms. So this need was growing by time, but I was unable to provide reliable information on that topic. And there are no guidelines. So the idea was to search the literature systematically, evaluate the safety and effectiveness of dietary interventions, and try to establish an algorithm to help and guide clinicians on that topic.
Okay, thank you so much. This is very clear for us. Could you summarize the findings of your study?
Yes, so our study is a systematic review on dietary interventions in endometriosis and includes original articles published in peer-reviewed journals until 2020. We found 9 human studies that followed one of the following dietary changes. 1, supplementation of specific dietary components. B, exclusion of specific dietary components. And C, complete diet modification. Most of them found a positive effect on endometriosis. So although a meta-analysis was not possible due to the high heterogeneity of the interventions and measured outcomes, our study provides an overview, a thorough overview of the published studies on this topic. So, to sum up the findings, a significant relief of general pain, dysmenorrhea, dyspareunia, and dyschezia, as well as an improvement in the general condition, was found after the implementation of a Mediterranean diet. Besides that, gluten-free, low nickel, and low FODMAP diets were also associated with pain improvement in the majority of the patients. 2 studies evaluated antioxidant diets with specific vitamins, fish oils, mineral salts, and also a significant reduction of pain symptoms was observed. And finally, 1 randomized control study found no significant effect of vitamin D on the pain outcomes. These are the main findings.
Great, great. So the global thing is very positive effect of the dietary intervention for our patient. This is very interesting.
Exactly.
To go a little bit further, what is your feeling about the overall quality of these articles? I heard you have a lot of positive effect, but how strong are these data?
Yeah, we evaluated that, of course, because it was a systematic review. So these studies, these 9 studies, are characterized by moderate or high-risk bias, possibly due to the challenges of conducting dietary intervention trials. It's not easy. And out of the 9 studies, 2 were randomized control studies, 2 prospective control studies, and then 2 prospective and 2 retrospective before-after studies without a control group, and 1 was a qualitative study. The follow-up period ranged from 4 weeks to 12 months. So this was also variable, and also the outcomes measured were very variable, pain scores and these things. So, but this is the available level of evidence, and according to what we have, we suggest in our article a clinical algorithm that could be used from physicians to use during their consultations with their patients. And for sure, however, more and higher quality original articles are needed to enable safer conclusions on the topic.
Okay, so the data is not amazing, but it's quite good enough to advise your patient to use this dietary intervention.
Well, the patients require some kind of guidance, and according to the level of evidence that we have, we should say something.
Yeah, okay, you can advise your patient. That's great. To go further for the patients, do you think that we should all evaluate as clinicians, as we are gynecologists, evaluate systematic the diet of our patients, or should we all refer our patient to a dietitian?
Well, there is no convincing data that all patients with endometriosis should be referred to a dietitian. This is not. But nutrition is widely recognized as a prognostic and modifiable factor related to morbidity and life expectancy. So besides endometriosis, so patients also with endometriosis should be advised and motivated to follow a healthy diet. I personally ask about their health habits, and if they repeatedly fail to adhere to healthy habits, such as Mediterranean diet, I advise them to visit a dietitian. And for sure, it will not harm, and most possibly, in the long run, it will help.
Yeah, you may have some bias because in Crete you've invented the Mediterranean diet. So maybe we don't have exactly the same in different countries, but I hear you. We need to evaluate systematically, and sometimes if we have a dietitian in our clinic or in our hospital, advise the patient to have a consultation with a dietitian. This is how we do also in the FMEndo, because we have the structure, and this is quite good for us. Could you tell us more about this this approach that you are starting to tell us about? Because in your article, there is this very nice figure, and I think it should be used, and we should talk about it, of the approach, the systematic approach for your patient. How do you manage that?
Yeah, so we developed an algorithm, as I said, that can be seen in our paper. It's a figure. So to sum it up, based on the promising results of the prospective before-after study by OT, an Austrian study, as well as considering the well-known health habits and no risk of Mediterranean diet, physicians may suggest this diet as a long-term dietary change. The benefit may be caused via various mechanisms, so antioxidant effects, but also eupeptic effect and gut microbiota improvement. If there is a difficulty in adhering to Mediterranean diet, like in France, due to cooking habits or personal daily life, a supplementary antioxidant diet may be considered for up to 6 months based on the randomized control study by CESTI. A longer than 6 months intake of dietary supplements should be, however, should not be suggested due to the unclear long-term safety of such interventions. On the other hand, patients with gastrointestinal related abdominal pain, bloating, constipation, so these kind of symptoms, they may benefit from a gluten-free, low nickel or low FODMAP diet, so excluding some products from their diet. However, the safety of a long-term use of low nickel has not been established, and a long-term low FODMAP diet can also have negative effects on gut microbiota, is also difficult to adhere and very expensive. And anyway, the start of these diets should be decided in a multidisciplinary approach, from my point of view, after also gastrointestinal evaluation in order to exclude other pathological diagnoses of the bowel. And it's important to have a multidisciplinary approach. As you said, in your clinic, you have also the facilities to use dietitian, gastroenterologist, and refer the patients if needed.
Yeah, that's very interesting. And it's important to say it again. It's evidence-based medicine, and it's an advice that you give with the patient with some arguments, some data in the literature. You can say, okay, first start with Mediterranean. I know why I'm advising you this. And I think this is very interesting because this is what the patient want to hear and want to know. How can you give me an advice that is strongly, that has data on it? And this is why we're here today. It's very important.
But Adrian, you're right. Mediterranean diet is the most difficult probably because you need to change everything. So
yeah,
it's difficult to
yeah,
change everything. You know, you learn how to cook from your parents or from your friends, and then all of a sudden I say Mediterranean diet. What they mainly want is something to exclude or something to add.
yeah.
And the safety of such interventions on the long term, so more than 6 months, is not established.
Yeah, especially when you ask them to exclude half of what they eat every day. I mean, it's very hard, and
yeah,
maybe we can talk about that, but maybe it's a reason for the limitation of the clinical application of maybe this is why they abandon so much. No.
Yeah, I agree.
Yeah, if you start to exclude a lot of nutrients, that's very important. Do you think the cost of this Mediterranean approach or the fish oil and stuff like that may be another limit?
Of course, it's higher cost. Absolutely, you need fish, you need fresh vegetables. You should avoid junk food, which is very cheap, mainly. Absolutely. So it's a total change of your personal life if you want to adhere to such a Mediterranean diet. And even in Crete, patients don't do that.
Yeah, and as I was looking at your figure, there is supplementation of vitamins, B6, A, C, E, mineral salts, and magnesium and stuff like that. This is stuff that you should buy to a pharmacy. It has cost, and you have to take them every day.
Yes, it has cost, but it's the easiest thing, you know, to take a tablet with a multivitamin tablet. It's the easiest.
Yeah.
Okay. But it has costs. Interestingly, also on the pharma industry, least here in Greece, produces such products, and also for patients with endometriosis, because also they realized the commercial interest.
Yeah, yeah, it's important to talk about that because we find a lot of these oral complements or diet complements. I don't know how you call that in every country. It's different. Sometimes it's you buy it in the pharmacy. Sometimes you can buy it for free anywhere. You can buy it anywhere, and there is no kind of limitation of control of what is inside of these pills. And this is where is the difference between proof in the literature with some of list of vitamins, specific vitamins, and everything that you can put is in some pills that you can buy anywhere. So I think we need clear and true information that this is why what you're giving us today. In my consultation, and I don't know how you feel about that, but I see patients experiencing this treatment failure, hormonal treatment failure, sometimes surgical failure, pain after the surgery, or pain with the hormonal treatment, or associated infertility. And they turn back of the classic treatments and they go to oral supplements, what we're talking about. And sometimes they feel like there is the kind of empowerment, like they were preparing their own drugs, I do my own medicine. This is sometimes what they say. And we didn't talk about that. And I think this is the very good message to bring. What are your thoughts on the potential toxicity of these products? I mean, can we take any vitamins every day at any dose? Is it okay? How do you advise your patient?
Yes, Adrian. And so from my experience also, it's mainly patients asking for dietary changes. And because indeed there are failures, non-responders in medical therapies, failures after surgery, chronic disease. They want indeed a self-management of the disease. It is good on the one hand. And so on the other hand, I mean, dietary supplement is, as said, the easiest dietary modification because you don't need to change something in your diet. You just add a tablet of vitamins. And there is also increasing marketing on that subject, and patients get this information. I advise patients that a longer than 6-month intake of such dietary supplements cannot be suggested due to the unclear long-term safety of such products. This is what they say clearly. And that they should also document after 3 months when they start such multivitamins, if they saw certain improvements in endometriosis associated symptoms. So I say they should document that. Did they really see an improvement? Okay, if they take it for 3 months, it's okay. If they don't see any improvement, they should stop it. If they see improvement, they can continue up to 6 months and then stop. This is what I advise the patients.
Okay, and do you follow the levels in the blood? I mean,
No.
do you? No, never. You don't do vitamin C level in the blood or stuff like that and compare it? No.
No, no, I don't do that.
And
I
do
don't
you
have
know
the
if there are
I'm not
some?
sure how to follow that. The only
Yeah.
thing that can be checked is vitamin D, which we check for other reasons also. Interestingly, there is one randomized control study in our article that found no benefit from vitamin D supplementation when there is no insufficiency. So if you have no insufficiency and you add vitamin D, you see no benefit as an endometriosis patient. But if you have insufficiency in vitamin D, you could do that. But
Yeah,
no, but
and
I don't know the levels in blood. No.
okay, and insufficiency in vitamin D is very common in our
Very common, yeah.
countries.
And also for vitamin D, very interestingly, there is also big studies that show improvement in dysmenorrhea, but not in, so there were not patients with endometriosis, just patients with dysmenorrhea. And supplementation of vitamin D helped, especially with the
how
lack
do you
of
do this supplementation? How do you, because I don't know if it's kind of for you, but we have different dose, different way of taking the vitamin D. How do you advise your patient? Is it every day or every 3 months, every month?
I do every day. It's drops, vitamin D, 30 drops. It's 800 or
Yeah.
1,000 I use per
Okay.
day.
And for this, they can use it for more than 6 months, right?
Not necessarily. I mean, they should stop it sometime. The level should go high, and that's good.
Okay.
They shouldn't use it forever.
Okay. If they feel that they control the disease, the efficiency of the vitamin D, they can lower the dose. Okay. So we talked about vitamin D. Let's talk about another interesting point, an interesting study, an Italian study that you included. In this Italian study, they show that most of the patients with gastrointestinal symptoms and endometriosis have a positive nickel test. Can you explain the pathophysiology of this disease? I mean, can you tell us more about the nickel test and the nickel allergy?
For me, it was also a new finding. I didn't know about this kind of diet, to be honest. And this was a pilot study, the Italian study, that included patients with endometriosis, symptomatic for gastrointestinal disorders, so all had gastrointestinal disorders. It was 28 patients out of 31, so 90% of the patients showed positive nickel skin test. And they followed low nickel diet for 3 months. Other studies have also shown higher rates of nickel allergy in patients with endometriosis, but even in the general population, it's high up to 30%. So nickel allergy could be an important cause of gastrointestinal symptoms in women with endometriosis, but without having necessarily a causal effect on the disease. So it's just a comorbidity mainly that causes these gastrointestinal problems. From my point of view, we need confirmation from bigger studies. This was only a pilot study. And currently, such a test, I don't have experience. It could be only proposed by gastroenterologists who are better qualified to raise the suspicion of nickel allergy. This is my point of view.
Okay, so no systematic test for nickel allergy, but it may be very common in our endometriosis patient. This is very interesting. Like you, I didn't know about nickel allergy because before we talked about it, and it's very interesting. And do you have any information where can we find nickel in what we eat? I mean, for me, I've never heard of it.
But there are certain diets that are available in the internet, how to avoid nickel. Difficult diet. So we are not specialized, I think, to counsel patients specifically on what to eat, what not to eat. They need then a dietitian to give them a catalog of products. Absolutely.
Yeah. Okay. Very clear. Thank you very much. So we talked about vitamin D, nickel. What do you think about low FODMAP diet and gluten-free diet? I saw that in your figure, it's a kind of population that has gastrointestinal related abdominal pain, bloating, that benefit from these diets. But those diets are often praised in the media like there were some kind of treatment for endometriosis, or in social networks we see a lot of influencers talking about the new diet that changed their life. Can the data in the literature that you went through withstand such a popularity of these diets? I mean, how strong are the data on FODMAP and gluten-free diets?
Well, we have to be careful, Adrian. Concerning the data, we have only one retrospective control study from Australia assessing low FODMAP diet in 160 patients with irritable bowel syndrome. So all had this diagnosis, irritable bowel syndrome. 60 were with a diagnosis of endometriosis and 100 without endo. More than 70% of the patients with endometriosis experienced an improvement of symptoms, over 50% improvement after 4 weeks of diet. And patients with endometriosis responded 3 times better than patients without. This is the one study that was included in our article. And one more pilot study came up last year from a Dutch group, also showing promising results. Interestingly, the low FODMAP diet is a very harsh diet, okay? Includes not only low nickel diet, but also low lactose, low gluten diet, so includes all of their diets. Or let's say it in other words, you take many nutrients out of your diet, and thus it's covering a large spectrum of high prevalence pathologies, such as lactose intolerance, non-celiac gluten sensitivity, visceral hyperalgesia. So all these comorbidities that may occur in patients with endometriosis, they are all covered. So even if you don't have a diagnosis, with this diet, you have a therapy of these other things in your bowel tract. So it's therefore possible to obtain clinical benefits from a low FODMAP diet, even if at the cost of probably not necessarily dietary exclusions, because it's, as I said, many exclusions in this kind of diet. But a long-term low FODMAP diet can have also negative effects on gut microbiota. So the start of these diets should be decided in a multidisciplinary approach, as said, after gastrointestinal evaluation, in order to exclude other pathological diagnoses. And of course, we need prospective studies with low FODMAP diets in patients with endometriosis and a clear description of their symptoms and comorbidities so that we can better elucidate this issue.
This is very interesting. Finally, the data and the level of the data is quite low for the FODMAP, and we see so many patients using this this very harsh diet. As you say, don't go. The message, to be simple, is don't go to low FODMAP diet without the advice of your surgeon, of a multidisciplinary team, because it can be dangerous for a patient. This is very interesting. Thank you so much.
I agree. In the long term, it can be dangerous.
Yeah. Let's go a little bit straight to the point for a surgeon perspective. We heard a lot about in the last 10 years about preoperative enteral immunonutrition, because it has shown favorable effect on surgical site infection and fistula in colorectal cancer without malnutrition. So do you think that this immunonutrition, like it's like a preparation that the patient should take weeks before the surgery, and do you think this could be a useful approach in our preoperative care? Because as you said it before, patients with endometriosis may have some diet issues. Do you think it could be useful for endometriosis patients?
It's a very interesting topic indeed. So enteral immunonutrition, it means product enriched with arginine, glutamine, omega-3 fatty acids. Personally, I have no experience on that type of nutrition. And from what I know, from what I searched in the literature, it is mainly used in surgeries for the upper gastrointestinal tract, and mainly due to through an enteral catheter. But surely it could be of use in patients with endometriosis before bowel surgery. But we need data before introducing it, from my point of view. And the bad thing is that, I mean, the good thing is we have a low possibility of bowel complications in endometriosis. But since it's a low possibility, we need a high number of patients to include in a study so that we can evaluate such a product. For sure, it's an interesting topic. Have you introduced that? Do you have experience with that kind of nutrition?
No, we don't use that. I know that colorectal surgeon use that this product to prepare the patient and to have higher protein levels in the blood, especially. And it's very important that it's very interesting that it works even in patients without malnutrition. And our patients with endometriosis are young. They look like they are in good shape, but as you've said it, they may have some deficiency in vitamins, proteins levels, because they eat low or no lactose and stuff like that. So I think it would be a nice approach, not maybe systematic, but a nice approach to prepare the patient for surgery with a tailor-made diet. I think that would be the future. I don't know how you see the future of the diets, but I think there should be a tailor-made approach by a multidisciplinary approach. What do you think about that? How do you see the future in your center or in the?
You mean like a precision diet for each patient?
Yeah.
It's very interesting. Yeah, I mean the future could be also check the gut microbiota, and according to the results.
So some kind of sample of the feces of the patient, or some blood test or some salivary test we can imagine to have the microbiota card, I mean, identity of the patient, and then do some tailor-made diets. That would be very interesting. I think we will go. Yeah, I think we will go in this direction to have specific intervention for our patient. We are arriving at the end of our talk. Thank you so much, Konstantinos. It's so interesting to talk with you, and I feel like this is how we should manage our patients. You know, look through the data, look for important information, look for the data in the literature, and then advise our patients with multidisciplinary teams. Thank you so much. You are the first guest of the EndoTalks podcast. I'm sure that many colleagues and patients will learn a lot from you. Thank you so much for the listeners of our podcast.
It was my pleasure, Adrian. It was my pleasure and an honor to be the first that talked in your EndoTalks. I'm keen to see the next interviews. Thank you very much. I'm a fan of Bordeaux Center. Many greetings to Professor Roman. See you soon, Adrian.
Thank you very much, my friend. Bye.